So I am here with Dr. Elizabeth Ortiz, who is a rheumatologist based out of Dallas, Texas. And I wanted to bring her on, one, because she has an awesome YouTube channel educating so many people about rheumatology just in general, but rheumatologists can play a huge role in osteoarthritis management. And a lot of times it gets missed out on. Most of the time it's go to your primary care doctor, or go to a surgeon, or go to an orthopedic doctor, but rheumatologists play a vital role, even when it's not rheumatoid arthritis, because that's one thing that I hear also. And so I am going to have Dr. Elizabeth introduce herself, and then also just let us know a little bit of how you got into rheumatology yourself. And then we will go into what rheumatology is, how they can help with osteoarthritis, some common pain causes when it comes to osteoarthritis, and then what to look for when you're looking for a rheumatologist. So take it away and let us know how you got here.
Yeah, no, thank you so much for having me. I always like talking about arthritis and rheumatology, so it's certainly a pleasure. I got into it the more I realized that rheumatology covers a very wide breadth of conditions. So we have autoimmune inflammatory conditions that really can affect the entire body. And in severe cases, people can need chemotherapy, people might need to be in the hospital. And then way on the other side of the spectrum, you have things like osteoarthritis, fibromyalgia, things that might be more mechanical in nature, although we're learning more and more that, shocker, there's more to it than that. But it's like there's this wide breadth of conditions that we take care of. And in some ways that can be challenging, but it's also what I really like about the field. It also is a field of you get to know your patients, like you see them regularly over a long period of time. I'm not a cardiologist that goes in and does a cath and then never sees you again. I don't go and do colonoscopies. Like what we do is we see you regularly and we kind of tweak things and help you kind of manage and adjust your lifestyle to whatever condition you're dealing with.
Yeah. Absolutely. And I think that is, like I said, they can really treat a lot of different conditions, but most of the time people like, oh, I don't have rheumatoid arthritis, or I don't have like an autoimmune condition. So I was shocked when, the amount of diagnoses that can go through rheumatologists. And especially when it comes to chronic conditions like osteoarthritis, it's always good to get a second opinion of something, like going maybe outside of your primary care, just getting somebody to kind of look at it a little bit differently, which I think is so important. And so what do rheumatologists do in terms of osteoarthritis? So do you do tests? Do you prescribe medications? What are some of the things that you do to help people with osteoarthritis?
Yeah, so osteoarthritis is one of the most common things we see in a rheumatology clinic, but I will say it's not usually what brings people to a rheumatologist. Okay. What brings people to a rheumatologist is just joint pain. So someone will be having difficulty with their knees or with their back or their hands, and they maybe have talked to their primary care doctor, maybe some tests have been done, but they usually get sent to a rheumatologist because the concern is that they actually have rheumatoid arthritis or some other inflammatory arthritis. Okay. And so we don't typically have people knocking on our door just for OA. It'll be for pain to figure out if it's something else. And then we go through our tests, we kind of do our exam and talk to the person and do our testing. And then a lot of times find out actually, no, it's not RA, it's not lupus or anything like that. And what you actually have is osteoarthritis. And then we can talk to them about how best to manage it, why it happened, and things to look out for. But unfortunately, I think it's unfortunate that a lot of people don't come just for OA. But we end up seeing a lot of OA because, number one, it's very common, and people will come to us for joint pain.
Sure. And I think that that's I know that some of the people that I've talked to have kind of started shifting towards osteoarthritis and seeking out rheumatologists because they are getting kind of frustrated with the answers that they're getting from other healthcare professionals, primary care surgeons, and a rheumatologist, like I said, can help give another opinion. But I do meet quite a few people who have sought out a rheumatologist just to kind of get like that second opinion and to maybe get some other options.
That's great to hear. That's great to hear. And you're absolutely right. Like I'm just listening to you talk, there are patients who have been seen by an orthopedic surgeon and don't maybe feel like they're getting any answers, or the only answer that they're given is surgery. And for whatever reason, they don't want that, or they're not ready for that, or they just want a second opinion. And so then they'll come to a rheumatologist. So I would say kind of both of those scenarios are how we end up seeing osteoarthritis.
Sure. And then as far as if someone comes to you and you find out that it is osteoarthritis, as far as some treatment options, because I know a lot of people listening to this video or listening to the podcast are interested in these natural approaches or natural ways to help with osteoarthritis pain, and even some natural or non-natural. Like there is definitely a time and place for medications and things like that. So what would you say are kind of like your first line of defense? And I know that it's going to depend on the severity and the person. But what are some of the treatment options that you like to explore for osteoarthritis?
Well, I think the first thing I always, before even getting to the treatment, once you've made a diagnosis of osteoarthritis and you have to really kind of gauge the severity, how severe it is. And I don't necessarily mean like on an x-ray, but like how much is it impacting their life?
Absolutely.
Like how much is it impacting their quality of life and getting in the way of the things that they like to do? And that's where you really kind of dive into their lifestyle and what is their life like? How much are they moving? How much are they not moving? And what kind of things that they used to do? Has the arthritis gotten in the way of certain things? Like the x-rays and all those things certainly help give you an understanding of the anatomy, but when it comes to pain and function, you've got to sit down and talk about what day-to-day life is. And that will give me a base, it gives me a baseline to then talk about what we're going to do about it. If someone is like severely debilitated, having to use a walker or a cane, then of course I'm going to recommend physical therapy. We might talk about a joint injection. We might talk about some pain medicine, but physical therapy is always going to be number one. And it doesn't matter if it's mild or severe, physical therapy has to be a part of it. And in fact, I will not even, because a lot of times people will be like, just give me the injection. I want an injection, because they hear about joint injections. And I mean, we can talk about that if you want, but because there's some mixed data on that and a lot of different opinions. But I won't even talk about a joint injection unless we're also talking about physical therapy, because you have to start moving. You have to, otherwise, otherwise you might end up going back to the surgeon.
Exactly. And on the term of injections, I do kind of want to go into that a little bit further, but I always tell people that even if you get a joint injection, you have to be able to maximize the benefit of it, that it's going to, you're going to not see as many benefits as time goes on, and it's going to kind of wear away. But if you can maximize the benefits, like what are you going to do when you experience this pain relief? Are you going to, start moving more? Are you going to start doing exercise? Are you going to start to do some of these things? Or else if it's just going to be, I'm just going to go on with my daily life and, continue to sit and lay down and things like that, then you're in this vicious cycle of just needing a or an injection, whether it's cortisone or something else, just over and over and over again. I know that injections are very, very common, and
they're very popular. Yes.
And some controversial research. So if you just kind of want to go into that, maybe how you approach joint injections, or which ones maybe you recommend over others. Again, I know it's going to depend, but kind of some more information.
So in the world of joint injections, there's really like 4 that come up. the kind of gold standard joint injection that's been around the longest are going to be a steroid injection. And there's different types of steroid injections. Some, it's really based on the potency of the steroid and how long they last in the joint. But the idea is that the steroid gets injected into the joint that has some local inflammation. So if your knee, if it has a lot of arthritis, there can be some inflammation in that knee. We talk about rheumatoid and osteo, and rheumatoid is an inflammatory arthritis, and that's correct, but it tends to make it seem like osteoarthritis has no inflammation at all, and that's not true. It does. It's just local in the knee. So anyways, you can do a steroid injection to lower that inflammation, and it will help with pain. You can also kind of what we call an arthrocentesis. So you take fluid out of the knee to really help with some of the pressure that's built up in that knee. And so that all helps with pain in the moment. And when I say in the moment, it can help between anywhere from 3 to 6 months. Some people get a year's worth of benefit from it.
Right.
In the past, it was felt that you could do these injections every 3 to 4 months. No problem. And like most things, you find out, oh, actually, there are some side effects, like we shouldn't be doing this. And now we have a better understanding that that's not ideal. And that if you are doing steroid injections too often, you can actually cause more problems, and you can get weakening of the surrounding tendons and ligaments. And the menisci, when we're talking about the knee, it can actually worsen the damage. So I don't look at them anymore as the kind of, okay, we're just going to put you on the steroid track. I think of it as a bridge. So when you come to me and you are in significant pain and you're really limited, and we need to get you to the place where you can actually do the exercises and the physical therapy, then these injections can help you. And it's like a bridge. Beyond steroid injections, we have a set of injections that we call viscosupplementation, and they are medicated. They're new-ish. When did they? Maybe like 15 years ago, they really started gaining popularity, and they are hyaluronic acid in different formulations. And you can inject it with steroid, or you can inject it by itself. And the theory when they first came out was like, oh my God, this is great that you're going to inject this into the joint and it's going to pad the joint. It's going to provide it's going to serve as the cartilage that's been wearing down. And of course, that's like not what's happened. It's like, it's the same kind of deal that you can get 6 months to a year benefit, and it does seem that in some individuals, it can delay the need for a joint replacement. But that is, in my view, really dependent on how active the person is and how much they engage in things like physical therapy. But that's another option. So if someone is really in a lot of pain and either has diabetes or has had a lot of steroid injections, so they don't want to do a steroid, you can do something like a hyaluronic acid viscosupplementation injection. Okay. Then you get into PRP and stem cells.
I was actually just going to ask about that.
Yeah. So that's like a whole other thing. So PRP is platelet-rich plasma, and that got a lot of attention maybe 10, 12 years ago. I used to work in LA, so it got a lot of attention because of Kobe Bryant. Okay. Because Kobe Bryant was injured and he got these injections, and it was like a miracle. And so then all of a sudden people wanted PRP. And what it is you take a blood sample, and then they spin it down in a centrifuge and only get the plasma and the platelets. And then they take that and inject it in wherever they want to inject it. And PRP is being used for joint injections, for soft tissue injections, for facials. It's being used everywhere with very limited data. And in fact, a study just came out with osteoarthritis of the knee, again showing that compared to saline injections, so a placebo, no benefit in pain or function. So okay. So doesn't mean that you can't find it out there, and it doesn't mean you can't find reputable doctors who will do it. And the way I look at it is, if someone has not gotten any relief from anything else, and they're trying their best in all the other aspects of their lifestyle and their movement and their diet and everything, but they want to try something, the risk-benefit ratio is still probably in their favor, and meaning that it's not that high risk. Okay. And so that's the way I look at PRP, that most likely not going to work. There's not as much data, but when you find yourself in a position where you just want to try something and your options are limited, it's worthwhile to investigate. Stem cells, however, I have a different feeling of, because I mean, if there's poor data on PRP, there's like really bad data with stem cells. And the thing that people don't understand is the word stem cells is not specific. And so studies will come out saying, well, this stem cell injection worked or this one didn't, and they could be talking about completely different things. And so one of the things that, the pain people and orthopedists are trying to do is just standardize what they mean by the word stem cells. Like, is it mesenchymal cells? Is it coming from fat? And those things make a difference. And so when you go to your local, pain injection clinic and they are advertising stem cells, it's actually might not be the same type of injection that was studied. So it's still very much the Wild West when it comes to stem cell injections. And so those I don't typically endorse.
Okay. And that's good to know, because I know there's all sorts of different opinions and things out there. You can get down a rabbit hole online of things. And I know there are a lot of people out there really trying to kind of find whatever it is that can bring them relief. That doesn't necessarily mean a new joint. But I also think that it's a lot of times people go to these routes before even looking at lifestyle factors and before looking at things like right around home that we can kind of clean up first. And so what are some of the common lifestyle factors that you do talk to patients about typically when it comes to joint pain and osteoarthritis?
Yeah. Well, I mean, I think you're absolutely right. The things about injections and pills, it seems like it's a much quicker fix than looking around and incorporating some habits into your life. And the one thing before even getting into what needs to be changed is I like to make sure people understand that just because you have arthritis on an x-ray or you can feel your bones have changed doesn't mean you're destined for a lifetime of pain. Pain is different than arthritis. I have seen a lot of patients who on an x-ray, you're like, oh my God, how are you walking? But they're perfectly fine. And then I've seen the flip side of that, where someone has some minimal arthritis, but has significant levels of pain. So pain is very different. And so when you're talking about how to approach pain, I always say, you got to have the basics in place. So sleep, diet, movement, and relationships, which I also kind of then put in with stress management, because all relationships are stressful. But you got to have all those things in check. And so, this is what can be frustrating sometimes with our medical system is it's not often or common that you get into those things with your doctors, even with a rheumatologist. But is your sleep restful? Yes, you want to have anywhere between 6 and 8 hours every night. And I've certainly had people who can get a little less than that, but they feel rested in the morning. So the real question is, are you resting? And do you feel rested? And if you're not, then we need to figure out why. Is there any sleep apnea? Are you having any anxiety? Anything like that? Movement, we've talked about. And, when someone hasn't been moving regularly, and then we're talking about trying to get going, I always recommend doing it under the guidance of a physical therapist, because you don't want to hurt yourself.
Exactly.
And having someone who is knowledgeable about movement and all those things, I think is helpful. Diet is interesting because it's so individual. And so the first thing I try to get at is like, well, what are you eating now? And not even like the granular, like give me your diet list, but more like, how often are you eating out and how often are you cooking? And if that balance is way on the restaurant side, then we try to get it more on the home side. And not even getting into specifics like eat this, eat that, but just like, let's shift you to now you're eating at home. And then try to get into helping people take note if there are particular meals or particular foods that tend to flare up their arthritis. Because
Yes.
everyone is so different, I always hesitate to give blanket diets or blanket recommendations. I mean, there are some foods that are kind of typically known to be pro-inflammatory, sugar being one of the biggest. But I think even before kind of giving that blanket, like avoid all sugar, because I mean, who wants to do that? That's not a life. That's not a life,
Exactly.
but it's more like noticing, how do you feel after you eat certain foods? I will say a lot of people with osteoarthritis notice red meat can cause them a lot of pain. That is not something that's scientifically backed, but just from my experience, like everyone says that red meat really causes a lot of pain. And big meals, like big heavy meals, and that also include a sugary dessert, that can make it, you kind of know the next day you might be a little stiffer. So instead of actual diet recommendations, I always just recommend just taking note, like paying attention,
Right.
and limiting how much you eat out, because we all know that when you eat out, there's a lot of salt and other things that you wouldn't necessarily put into your home cooked meal. And then the last thing is relationships and stress. 100% of the time, if you have a stressful week, day, month, your pain's going to be worse. It just is. And so what are you going to do to manage that stress? You know, we have to come up with some sort of stress management skills. And sometimes that's just some breath work. Sometimes it's meditation. Sometimes it's a therapist or a psychologist. You know, everyone kind of has different needs, but they all need to be addressed when you're talking about pain. And I will say, in my opinion, I think that's unfortunately lacking amongst doctors who take care of arthritis, to talk about all of those things, but they're really important.
Exactly. And I think a lot of times, like, exercise just gets thrown under the bus, like slow down, only do certain types, when that might not necessarily be the cause of the leading cause, at least, of what's kind of flaring up that pain. And so people go to physical therapy or they try an exercise program and don't see much change, because that might not be, if they have, all this stress and they're, eating out a lot and doing all these other things, then you could exercise and do everything perfectly and still not see that relief. And so I think that's important, again, to kind of encapsulate all of the risks and things that increase the pain. But like you said, unfortunately, a lot of times it's blamed on, lack of movement, which is a huge one, but dives into some of this other stuff that just gets commonly kind of flown under the radar. I meet a lot of people who have been in pain for a long time and don't ever, and they're, they know they're anxious, they know they're stressed, and don't ever even know that like a psychologist is an option, or something like that. Like, I have, like, my joint is hurting. What does that have to do with? But it has so much to do with it. It
has a lot to do. And, we are understanding so much more about the pain pathways than we ever did before. In rheumatology, we also take care of fibromyalgia, and the arc of how fibromyalgia has been understood has really kind of pushed scientists and researchers to expand the thinking about pain in general. And I think that things like osteoarthritis have benefited from that kind of opening Pandora's box about, like, where is pain coming from? And it's not just bone on bone is causing the pain. No, the pain you experience is actually a neurologic issue. It's the way that the nerves around your joint are communicating with your brain. And that really doesn't have much to do with the bone on bone that we might see on an x-ray. And so what are the things that can influence that connection? Well, sleep, movement, diet, stress, like those are the things.
Exactly.
Yeah.
And they all play into hypersensitivity of pain. I mean, you're just more sensitive when you have lack of sleep, when you are, heightened with stress. And even some certain foods can increase that hypersensitivity, which I'm sure that you've noticed as well. And so it's definitely a holistic type view. But what would you say? So if somebody is not in Dallas, Texas, and if somebody is looking for a rheumatologist, potentially more for like what we've been talking about, the holistic view, and because I meet a lot of people who have a hard time finding somebody that they really click with or really kind of looks at these different options, what would you say are maybe just some key things to, or maybe even questions to ask to someone if they're going to see someone new?
Yeah. Yeah, it's a good question because it can be challenging. And I say that as someone who loves rheumatologists, has a lot of friends who are rheumatologists. And I know, there are certain pressures to see patients in a short amount of time.
Yeah.
When it comes to finding the right rheumatologist for a particular person, it's really all about, do you feel comfortable enough to be honest with them? One thing I have found is I don't think patients go into it thinking that they're, going to keep something from their doctor, but they find that they are. And if that's the case, then that means that something's amiss between this relationship.
Sure.
And you can either try to fix it or figure it out, or maybe just say that you don't feel comfortable and you need to find someone else. And that's the other, like, people should definitely feel comfortable and confident that they deserve to get a second opinion if you don't feel comfortable. Like, everyone deserves to have a good relationship with their doctor where they feel they can be honest and open, even if it's a quick appointment, that you're not hiding anything from them. You don't feel like they're judging you, anything like that.
Sure.
And that's really personal, how someone clicks with one person, another person might not click. I'm a big fan of personal referrals. So if a primary care doctor has a particular rheumatologist that they know is good with their patients and takes time, that's always good. Online reviews, plus or minus, those can go either way. It's really hard to have a hard recommendation as opposed to just having one appointment and feeling it out and seeing how it is. As far as making sure that these issues are addressed, I definitely think going into the appointment with an agenda that you want to talk about XYZ is key. Because if you as the patient don't go in with the agenda that you want to talk about your sleep, or you want to talk about your diet or whatever, then chances are high it won't come up. So that's a good point. I really think it's for better, for worse, our responsibility as patients to go in there with our agenda. I also think it's worthwhile to think about utilizing these patient portals, that all doctors now use these electronic health records, and they all have a patient portal where you can message your doctor. I don't think a lot of us use that as effectively as we could. A lot of times you go in and you see the doctor and things are rushed, and maybe you're not thinking straight, because who is thinking straight when you're seeing the doctor? And you go home and you realize you forgot to ask XYZ. And so you send a message. That message, unfortunately, might not be given the same attention as it would have if you were talking about it in person. It also might require a lengthy discussion that's more than what can be typed out in a message.
Sure.
I find that the patient portal, and this is along the lines of sending the agenda, is best utilized if you send a message a week or a few days before your appointment saying, I have an appointment with Dr. So-and-so. I would like to make sure that we discuss XYZ, so that your doctor knows ahead of time to come in prepared to talk about XYZ. Now, they're going to have their own agenda as well. They want to talk about whatever, your labs or your x-rays or whatnot. But for them to walk in already knowing that you want to discuss these things makes a huge difference in how effective that appointment is and getting all of your questions answered.
Yeah. And I mean, that makes total sense.
And if you don't get to everything and they say, okay, we'll see you in 6 months, it is absolutely okay to say, actually, we weren't able to talk about everything on this appointment. Can we set up something in the next 3 to 4 weeks to continue the conversation?
Yes. And that's what I think a lot of times that disconnect comes from, where maybe patients don't feel like they can ask certain things, or feel like they're kind of stepping on the toes of the agenda of, the doctor, whoever they're seeing. And I think that Absolutely, being prepared. And I know that on your YouTube channel, you're putting out all sorts of information, and I'm putting out all sorts of information because it's to inform patients to ask about these things.
To ask, right?
Because they might not know like what to ask,
Yeah.
or,
No, I am like people, I think that when you're in healthcare, you get sucked into that world, and sometimes it's easy to forget that not everyone lives in that world.
Right,
And
right.
that people sometimes, they kind of know what they want to know, but they don't know how to communicate that in the room. And things are so rushed, and they're being talked at, and the doctor's looking at the computer anyway. Like, it's not an environment, unfortunately, that fosters like deep, thoughtful conversations.
Totally.
And so I have found the best way to get your answers question, whatever condition you're dealing with, is to go in with your own agenda and to share that agenda with the doctor. It's just like any other meeting you would have.
Sure.
Yeah.
And on that agenda, so we did talk about kind of those 4 or 5 main things to address if one of those pertains to the person not seeing the doctor. But is there anything else on that agenda to potentially ask for outside of the realm of sleep stress, like certain tests, or maybe other options, or maybe some medications? Is there something just to kind of ask to get more information, or maybe something that might be missed?
So, yeah. So again, when you're going for, let's say, hand arthritis, everyone's concerned about RA, or rheumatoid arthritis. And the way we make that diagnosis is obviously a history and a physical exam, because the findings that you see on someone's hands when they have RA are very different than what you see with OA.
Okay.
But that being said, sometimes it is kind of confusing. Sometimes the doctor cannot be quite sure. And so you need x-rays and labs. And the labs that are most useful are going to be the autoantibody called rheumatoid factor, the autoantibody called anti-CCP, or cyclic citrullonated peptide. And then they're going to do 2 labs that look at levels of inflammation called the SED rate, ESR, and the CRP.
Okay.
They're probably going to do a lot of other stuff, because rheumatologists just do a lot of labs. But when it comes to looking for rheumatoid arthritis, those are going to be the main ones. Okay. And, the rheumatoid factor, people assume that it's the end all be all because of the name, but the truth is it's not as specific as we like. And so that's what the CCP is for. CCP is much more specific. So let's say someone has a positive rheumatoid factor, but a negative CCP, that then requires some careful thought and consideration about what direction to go. So they have to put all these labs together. Like, there's not one lab that nails the diagnosis. Right. It's all of it.
And then with osteoarthritis, there's not really one either, right?
No, there's no lab for osteoarthritis. Osteoarthritis is made based on physical exam and x-rays. X-rays can be very helpful. And also x-rays, the changes that happen in a particular joint from OA is going to be different from RA. So if there's any question, x-rays can be very helpful. Okay. So as far as diagnosis and workup, that's what we would do, specifically if someone has hand problems. If someone comes in just with one knee that's bothering them, that's very unlikely to be rheumatoid arthritis. So your doctor will probably not go down that lab and x-ray road. Okay. It's mainly just if someone's having a lot of hand or foot issues. Okay. Your other about other medications. So yeah, there's a lot of other, aside from lifestyle stuff and aside from injections, there's topical anti-inflammatory medications. Voltaren gel just became over the counter. There's also, things like Icy Hot and CBD formulations. Then you have your oral pain medicines. So things like ibuprofen and naproxen, diclofenac, acetaminophen, and kind of how often to take it. Is it safe to take it? I mean, those things you have to look at your liver and your kidneys and all that. Like, sure. It really requires a whole full body evaluation. People go in thinking that, oh, I'm just going in for my knee, and you're just going to focus on the knee, but really to do a full thorough job, you got to look at everything. Yeah. Yeah, because you don't want someone taking too much ibuprofen if they have any issues with their kidneys, for example.
Right. And that's, I
Yeah.
mean, definitely asking, and even before even taking some of the stuff, even though it's over the counter, I mean, getting a more personalized approach, I think, because people
Mm-hmm.
are always asking, what type of medication should I take, Advil or Tylenol, or, and it just really depends on
Mm-hmm.
your current health situation and what you have
Yeah.
going on personally.
Yeah.
Um, and
No,
so
it really does.
yeah. And I mean, a lot of people then develop, I'm sure that you see this too, develop ulcers and things and had no idea that
Oh, yeah.
that they weren't supposed to take that, or they had issues with their kidneys, or something along those
Yeah.
lines.
Yeah. No, I mean, I, because it's over the counter, I think there's this feeling that, oh, there's no side effects. I can just take it as often and as much as I want. And no, it's not the case.
Exactly. And so, I mean, it's definitely from this conversation, definitely osteoarthritis, or really any condition. If you have, I meet patients that have like fibromyalgia too, or,
Mm-hmm.
another autoimmune condition. Some people even have, which I'm sure you've seen, a little bit of kind of rheumatoid and a little bit of
Oh, yeah, no, that's
osteoarthritis.
very common. Yeah, no, you can definitely have more than one type of arthritis, which can be a bummer. But when someone has rheumatoid arthritis, the thing about rheumatoid arthritis is it is a condition where the joints can not deteriorate, but you can get erosions. And so the joint architecture changes because of the inflammation. Now, we have amazing medicines these days that can really halt that. But some people either for various different reasons, just continue, they can get those erosions and that damage. And so even when the inflammation of the RA is controlled, they might still have some other limitations and pain related to the degeneration or osteoarthritis that has developed as a consequence. So yeah, no, people can definitely have more than one type.
Yeah, and I always recommend like seeking out someone like yourself, a rheumatologist, that they trust and vibe with, because if you're having like some other symptoms, and I'm sure that you can speak a little bit more to this, but other symptoms that don't necessarily align with local joint stiffness, local joint pain, like fatigue, not related to poor sleep, but also like feelings of like illness, or are there
Mm-hmm.
any other symptoms that maybe might flag that it could be rheumatoid arthritis, or part of the symptoms could be rheumatoid arthritis?
Yeah, so joint swelling is a big one. Now, joint swelling can certainly happen with osteoarthritis, but with rheumatoid, it tends to be a little more persistent.
Okay.
If you feel your hands in particular, because hands are the most commonly affected, if the joints are warm and kind of boggy, or you can't, your grip is decreased. Morning stiffness. I used to do a lot of teaching to medical students and whatnot. And I used to always say the one question that I think is the most important question to differentiate between an RA patient and an OA patient is morning stiffness. And someone who has osteoarthritis can certainly get stiff in the morning, and it can take anywhere between 10 to 20 minutes for them to get warmed up. Someone with rheumatoid arthritis, lupus, or any other autoimmune inflammatory condition that's causing arthritis, it's pretty remarkable how, like, on the dot, an hour. Most people say an hour, maybe an hour and a half.
Okay.
Fibromyalgia tends to be 2+ hours. Like, those are people who are stiff most of the day. But someone with RA, even without any kind of medication, will say right about an hour. So I always kind of use that as a differentiator. Of course, there's going to be
Interesting.
interpersonal,
Sure.
differentiations, but that's pretty universal. What else? Oh yeah, just like you were saying, kind of generally malaise, fatigue, lethargy, not feeling like yourself. Those kinds of things where you don't really feel that if you have osteoarthritis. If you have osteoarthritis, you have pain, and you can have limitations. And I've had people, tell me that they get grumpy because of the pain, but
Sure.
they don't necessarily notice that much of a difference in their energy level or feel like they have a flu coming on the way someone with RA does.
Okay. And I think that's interesting to note, just because if somebody maybe isn't having luck with certain things in regards to osteoarthritis management, that potentially seeking out and getting some, testing done and things like that, if they are having some of those other symptoms. Because I mean, I can imagine that it can be very dramatically impacted, because rheumatoid arthritis can respond better to some medications and things like that, which can make you feel better. And then
Yeah. Yeah. No, I oftentimes get the question, which is worse, RA or OA? I'm like, well, neither are great. Like the one that you're dealing with is the one that's most important. But the thing about RA is there's been an explosion of medications, like the research in the past 30 years regarding some of the pathways and the inflammation that happens in RA has really led to a lot of medications now at our disposal, which is amazing because 30, 40 years ago, we didn't have that. We really were just giving prednisone, which is horrible. But now we have a lot more targeted therapies that can really halt the progression of rheumatoid arthritis. And it has changed it from being a condition that was guaranteed to lead you to disability and a wheelchair to now living a full, non-disabled life, which is great. Yeah. Osteoarthritis has not had that level of research. It is now. I think now there's starting to be a lot more attention. But unfortunately, it used to just be considered, oh, that's just part of aging, and not much attention was paid to it. And thankfully now there is a lot more attention being paid, and shocker, it's a lot more complicated than just getting older. and there are different inflammatory pathways going on inside the joint themselves that now with our molecular technologies can be targeted as well. So I think that in the next 20 years, we're going to start seeing more coming out for osteoarthritis. But yeah, right now the focus is mainly on helping people's pain and improving their function.
Right, exactly. And as far as, we know exercise is going to be one of those primary ones, but then also some of these other things, other lifestyle habits, and then using some pain medications if you need them, and some of these other ancillary things.
Mm-hmm.
So basically, it's kind of finding that holistic approach of lifestyle factors and things like that, but then also kind of finding a healthcare professional that you vibe with and that can give their, opinions, and really try to find someone that you trust is going to give you the best option that you feel like you can talk to. And because that's a huge part of it. I mean, people can just sit there and tell you all sorts of different things. And if, it's not really what you want, or, I mean, people who don't want surgery, but then all their doctor's telling them is surgery, or, those people that are vulnerable, and then they see their x-ray and are told, oh, it's damaged, this is the worst I've seen, and sends them down this spiral of depression and isolation. And so those two things, I mean, I think are vital in the treatment of osteoarthritis, but also some of these other conditions as well. And rheumatology seems like the best piece for you if you're struggling with some of these other, like your primary care, asking them for a rheumatology referral, or even the orthopedic surgeon. And so is there really any last remarks? Also, I do want to just briefly talk about, so you own your own clinic, is that right?
Yeah, I have a practice in Dallas, Connected Rheumatology, and it's a different kind of rheumatology practice. I'm out of network, and I did that so that I can take the time to go over all these things that we've talked about.
I am totally with you on that one.
Yeah. So I see patients here in Dallas through my practice. And then I also have, like you mentioned, my YouTube channel, with the goal to kind of demystify what rheumatology is, talk about what I know are very common questions that come up in the rheumatology clinic, as well as just in general. I'm a rheumatologist, obviously, but I don't think my family really even knows what I do. Like
Exactly.
it's so, people do not know what rheumatologists do. Like even my father has osteoarthritis, and in his knees and was complaining about what the surgeon said. And I was like, you should be seeing a rheumatologist, right?
Exactly. Yes. And so if you are in the Dallas area and are looking for a rheumatologist, then I'm going to put your link down below to the clinic Connected Rheumatology, but then also the link to your YouTube channel so people can head there for more information. And then is there any last remarks that you have that you would like somebody to know, that if they're sitting there with osteoarthritis right now and maybe haven't seen a rheumatologist, or maybe they have, any last remarks as far as finding treatment options or anything else to explore when it comes to rheumatology?
I think the two biggest one is, just because you have osteoarthritis does not mean you have to have pain. So like understanding that. And so you don't just kind of reside to the fact, like, I guess this is just going to be the rest of my life. Like,
exactly.
no, it doesn't have to be that way. There are other things. There are things out there that can help you. There are people out there that can give you some information. And yes, it might require a little digging, and you might need to maybe have some bad dates with some other doctors before you find the one that's going to click. But you don't have to just reside yourself to being like, I guess I'm an old grandma now. No. Pain is different. You do not need to kind of suffer and you're not destined for this for the rest of your life. So that's the first thing I always try to make a point of saying.
I love it. Yes.
The other thing is, that everyone deserves to have a healthcare provider that listens to them and takes them seriously. And if you do not feel like you're getting that, it is absolutely your right to go find someone else. You're not going to hurt anyone's feelings. It's not about, even if it's the most lovely doctor that you've been with for a long time, if you're not getting your answers that you need and you're still suffering, you can go get a different opinion. Start asking your friends, ask your doctor, who else do you've got on your Rolodex? Who do you use? I know nobody knows what a Rolodex is anymore, but you deserve to be heard.
Yes. And I totally agree. And I think if you're not heard and you're not getting the answers you want, I mean, it can lead you down a path to disability when it doesn't necessarily have to. And so also, I think one of the main takeaways of this is advocate for yourself, that you can ask questions, you can poke and prod and see and get more answers, and, ask any of the questions that you have, and you have to advocate for yourself too. You can't just put your agenda or just go with the doctor's agenda, that you have to have your own agenda, like we had talked about before.
Yeah. And that's one thing I have come to realize, that going back to what we talked about, that people, they have an agenda, but it's like, it's not quite formed. And that's one thing I like to do in my videos is, if I'm talking about whatever topic, also include, these are questions you can ask your own doctor to understand where you fit in this, whatever we're talking about. Yeah.
And I think that, like I said, I think that's so important, even just to give some inspiration of that's a good idea.
Yeah. Get people thinking. Yeah.
Yeah. Cause you might not get that somewhere else, that's why I think it's so important, just even the YouTube world and just so much, all the information that's out there. Granted, there's some not so great information too, but
yeah, it's a double-edged sword for sure.
It is. But I just wanted to thank you so much for sharing all of this wonderful information. And I hope that this was super helpful for the podcast listeners and also the YouTube subscribers. So head on over to Connected Rheumatology is your YouTube channel too, right?
Yep.
Okay.
Everything's connectedrheumatology.com, Connected Rheumatology on YouTube. And also I'm in Instagram and Facebook. It's all Connected Rheumatology.
Okay, perfect. So if you want to go take a deep dive in Dr. Elizabeth's information, feel free to head on over to any of those platforms. I'll put the links down below. And I just want to thank you so much for your time. I think that this was very, very valuable. And thanks again.
Oh, well, thank you for having me.